How would you assess the skin integrity of Mr. Smith?
For Mr. Smith, who has light pink skin, it was noted that he had hyperemic areas on 3 turning surfaces that lasted approximately 1 hour. At this juncture, the nursing home staff decided to place him on a Group 2 support surface to better redistribute his pressure.
You mentioned the use of Group 2 support surfaces. What different types of support surfaces might a surveyor see used in nursing homes?
The use of support surfaces on beds is an important consideration in helping to redistribute pressure. It has long been believed that support surfaces fall into 2 groups: pressure-reducing support surfaces, which reduce pressure but not completely below 32 millimeters of mercury, and pressure-relieving support surfaces, which reduce pressure below 32 millimeters of mercury. However, within the last few years, the world community has embraced the concept of pressure redistribution, which notes that since we can never totally relieve pressure, the best we can do is redistribute pressure. For example, if we relieve pressure on the heels, we will most likely increase pressure somewhere else on the body. Group 1 devices are those support surfaces that are static. They do not require electricity. Static devices include air, foam, whether the foam is convoluted or solid, gel, and water overlays, or mattresses. These devices are ideal when a resident is at low risk for pressure ulcer development. They redistribute pressure, may decrease sharing, and are relatively inexpensive. If foam is used, it should be 1.3 pounds per cubic foot and greater than 3 inches. Group 2 devices are powered by electricity or pump and are considered dynamic in nature. These devices include alternating and low air loss mattresses. These mattresses are good for residents that are moderate to high risk for pressure ulcers or have full thickness pressure ulcers. The advantages of alternating air mattresses include portability, redistribution of pressure, reduction of sharing, and they are moderately priced to purchase or rent. The disadvantage, however, of these mattresses is their inability not to reduce heat accumulation on the resident's body. The advantages of low air loss mattresses are pressure reduction, low moisture retention, and reduction of heat accumulation. The disadvantage, however, of low air loss beds is that they can be expensive to purchase or rent. Finally, Group 3 devices are also considered dynamic in nature. This classification comprises only air fluidized beds. These beds are electric and contain silicone-coated beads. When air is pumped through the bed, the beads become liquid. They are used for residents at very high risk for pressure ulcers. More often, they are used for residents with non-healing full-thickness pressure ulcers or when there are numerous truncal full-thickness pressure ulcers. The advantages of air fluidized beds are their ability to redistribute pressure and to reduce heat accumulation, moisture retention, and shearing forces. The major disadvantages of these beds are their ability to restrict residents' movement, and they are expensive to purchase or rent. There remains a dearth of research that demonstrates significant differences within the support surface classifications and preventing or healing pressure ulcers. Therefore, the level and type of risk factors should guide the level and type of support surface that is selected.
Thank you, Dr. Leiter, for this information. It will be very useful for both the surveyor and for facility staff in assessing the risk factors for residents in nursing homes and for the provision of pressure redistribution.
She'll be on one camera.
I have several questions about what we previously discussed. First, I have a question about maceration. You had addressed maceration in relation to urinary or fecal incontinence and its effect on the skin. I understand there may be other examples of maceration.
Yes. Yes, Sharon. Maceration can occur from many different sources. On this slide, you will see a foot which had an ulcer on the bottom. The ulcer was being treated with wet to dry dressings. Maceration occurred, as noted, in the white areas by the excessive application of moisture. So you can see it's important for the staff to be aware of how the skin is reacting to the treatment that's being used.
How do you offload for 1 minute if you can't bear weight? If you can offload for a minute and then reseat the resident, how long can they then be seated in that position? And when is offloading appropriate?
Great question, Sharon. Offloading is critical to pressure ulcer prevention. When the resident is sitting, they should be offloaded at least every hour. When offloading, the staff member should have the resident off their ischial tuberosities for at least 1 minute to promote good tissue perfusion. At this juncture, if the staff could do a quick skin assessment to identify any areas of redness, then prevention can be implemented.
When we talked, you said a little about assessing darker pigmented skin. Our MDS data reveals that there are about 2,000 residents with darkly pigmented skin out of 1.4 million people. Staff might not have had much experience in noting changes that occur to the skin when a stage 1 is developing.
Yes, that's why it's so important to note that pigmentation affects the way that erythema is manifested. When assessing darkly pigmented skin for erythema, the staff must take their time using the right light and tactile senses to identify the erythema in this very special population.
Dr. Leiter, I was particularly interested in your discussion of newer technologies in identifying stage 1 ulcers. Now, you mentioned that high-frequency ultrasound was being used. You have any experience with this in your particular practice?
Actually, Stan, yes. I've used this technology, which is not dependent on skin pigmentation. In my nursing homes, we have implemented high-frequency ultrasound when the resident is first admitted at least once a week. The resident's major pressure point areas are scanned to determine early breakdown. Clinically, I have found high-frequency ultrasound as a good assessment tool.
Before we proceed, let me just remind our viewers that they can call in with questions or they can fax in with questions. So let me give you those phone numbers right now. If you'd like to phone in your question, the number you should call is 1-800-953-2233. If you prefer to fax us your question, then you should dial 410-786-0123. I'm Sharon, I interrupted you for a second.
That's okay. I was wondering, when we talked before, we were speaking about assessing for risk factors for pressure ulcer development and identified some strategies that a surveyor might see used in nursing homes. We surveyors observe the actual treatments of nursing home staff as they provide it to the residents who have pressure ulcers. Dr. Leiter, what can you share with us about the clinical importance of staging ulcers?
Sharon, staging pressure ulcers is one method of classifying certain characteristics that exist within the ulcer. In particular, it is helpful in determining the extent of tissue damage. There are many staging systems used throughout the world. Some countries use a 2-stage system, while others may use as many as 6 stages to classify an ulcer. However, in the U.S., a 4-stage system to classify pressure ulcers is most commonly used. Let me go through the 4-stage system most commonly used in the U.S. Stage 1 pressure ulcers are very common ulcers. Here we see a stage 1 pressure ulcer on the lateral aspect of the heel. The epidermis is intact with a rubric appearance. You can actually note in the center of the ulcer some capillary destruction. Here, in the next slide, is a stage 1 ulcer in a resident with darkly pigmented skin. In this resident, you can see the classic appearance of bluish-purple hues compared to the adjacent tissue. Now, let's look at the stage 2 pressure ulcer. Clearly, there is some ecchymotic area with exposure of dermal tissue. There is no evidence that the destruction is below the dermis level. In contrast, this stage 3 pressure ulcer exposes the subcutaneous tissue. There is evidence of slough and necrotic tissue on the wound bed. There is some evidence at the 6 o'clock position of undermining. And finally, the stage 4 pressure ulcer exposes the fascia. This pressure ulcer is relatively clean with granulation tissue present. However, there is evidence of some undermining.
Dr. Leiter, can I stop you here? When you described a stage 2 ulcer, you said that it can present as a blister. Are you saying that all blisters are stage 2 ulcers?
Well, according to the NPOAP staging classification system, blisters in pressure-related areas should be classified as a stage 2. Clinically, for those blisters that I cannot observe the base, such as a blood blister, I would document a blood blister noted. Minimally, it's a stage 2. Another staging challenge that Dr. Berlowitz mentioned is delineating between a stage 1 and deep tissue injury. Clinically, I've observed a resident who had an area, for example on his heel, in which the epidermis was intact and was purple, yet when you palpated that heel, it was quite boggy. Technically, using the NPUAP staging system, it would be a stage 1. However, clinically, I have serious suspicion that the tissue goes deeper than the epidermis. Thus, I would classify it for the MDS as a stage 1, but in my medical record, I would note it's a deep tissue injury, as Dr. Berlowitz has previously discussed. This again illustrates that the current staging system is not perfect, yet it does provide the clinician with valuable information on the level of potential damage so appropriate treatments can be implemented.
This is interesting. When surveyors review documentation regarding the way of pressure ulcer, we see a variety of descriptions for that ulcer. From your experience, what is essential to document?
When a pressure ulcer develops, a comprehensive evaluation is necessary. Clinically, I believe there are 8 characteristics that should be evaluated and documented. 1, the location of the ulcer, the stage of the ulcer. The area of ulcer, I would record the diameter for a circular ulcer. For those pressure ulcers that are irregular shaped, then I record the lengths of the largest perpendiculars. I use a wound ruler that measures the ulcer in centimeters. The key is doing the measurements consistently. I would identify on any wound a clock. So 3 o'clock is always in the same position. This helps to increase my reliability. Depth, I would measure depth from plane of skin, probe with a Q-tip and measure the extent of undermining. Also look for sinus tracts. I would also measure drainage. You want to estimate the amount of drainage, identify any odor or purulence. You also want to assess and document necrosis. Any devitalized tissue should be noted, the amount covering the ulcer. Granulation, we want to identify the amount of granulation tissue present, since that's a good sign that the pressure ulcer is healing. You can also see a regression of granulation and or tissue friability when the ulcer may have an infection. And finally, 8, fasciculitis. Look for erythema surrounding the wound, and there may be induration, tenderness, and warmth in the area.
Dr. Leiter, that type of documentation would provide surveyors with the things that they need to know. Surveyors may find this information you described in a variety of locations in the resident's record based upon the facility policy. Are there validated tools that clinicians might like to use to measure pressure ulcer healing?
Presently, there are 2 tools that have been widely used for measuring pressure ulcer healing, and both have been validated. The pressure ulcer scale for healing, also called the PUSH tool, was developed by the NPUAP, and the pressure source status tool, or PSST tool, developed by Dr. Barbara Bates Jensen. The PUSH tool requires less time, as it only has 3 items as compared to the PSST tool, which has 13 numerically ranked items. As the wound heals, the scores for both tools become lower.
Dr. Leiter, one area that you have not mentioned is using reverse staging as a method of measuring healing. Any thoughts?
I'm actually glad that you brought this up. In 2000, I chaired the special NPUAP committee to address this very issue. In 1989, due to the lack of research-validated tools to measure pressure ulcer healing, clinicians were resorted to using pressure ulcer staging systems in reverse order to describe improvement in an ulcer. We now know that as pressure ulcers heal, they do not replace lost muscle, subcutaneous fat, or dermis before they are reepithelialized. Instead, the pressure ulcer fills with granulation or scar tissue composed primarily of endothelial cells, fibroblasts, collagen, and also extracellular matrix. Thus, according to the NPUAP, as a stage 4 pressure ulcer heals, it does not become a stage 3, stage 2, and then subsequently a stage 1 ulcer. When a stage 4 ulcer has healed, it should be classified as a healed stage 4 pressure ulcer, not a stage 0 pressure ulcer. Therefore, reverse staging does not accurately characterize what physiologically is occurring in the ulcer.
Thanks, Dr. Leiter. Well, I understand that clinicians may document in the medical record a healing stage 4 pressure ulcer. The MDS currently requires the clinician to reverse stage. Now that we've heard about the assessment, the types of ulcers, the prevention and staging, let's talk about the treatment of pressure ulcers. Dr. Aiello, it seems that there has been a change in the way clinicians approach wound healing. Can you tell me something more about this?
I'd be happy to, Sharon. Remember when wounds would form scabs? Years ago, we used to actually dry out wounds by keeping them open to the air or covering them with dry dressings. We now know that this actually delayed healing, since the cells needed to close the wound have to burrow down below the wound bed to get to the other side of the wound edge. This takes more time for the cells to get to the other side, so it took longer for the wounds to heal. The way to heal wounds has actually changed based on the scientific evidence of Dr. Winter.
I'm not familiar with the work of Dr. Winter. Can you tell me more about his research?
Dr. George Winter's research in the early 1960s gave us evidence that wounds heal better in a moist environment. By covering the wound with a dressing that kept the wound bed moist, the cells needed to close the wound can now actually move across to the other edge of the wound. Since they don't have to travel down below the wound bed, they reach the other wound edge quicker, so wound healing is faster. Other effects of moist wound healing environment include improved collagen synthesis and granulation tissue formation. Cellular migration and epithelial resurfacing occurs much faster. And finally, a moist wound environment prevents the development of scabs, crusts, and eschar.
Well, that explains a lot about wound healing. But then why is it that even when we maintain a moist environment, chronic wounds, such as pressure ulcers, are still so difficult to heal?
Once again, Sharon, the answer lies in the growing amount of research examining the composition of wound fluid in acute and chronic wounds. Scientists have identified a variety of biochemical substances that are important in wound healing. Acute wounds follow an orderly sequence of events that result in the normal repair of tissue. It seems that unlike acute wounds, many chronic wounds, such as pressure ulcers, are biochemically different, and the usual healing process is disrupted in chronic wounds. There is an increased amount of pro-inflammatory cytokines. There's an increased amount of matrix metalloproteases, or MMPs, coupled with decreased amounts of TIMP, or tissue inhibitor metalloproteases, which normally counteract the effects of MMPs. This results in more breakdown of the very tissue proteins that are needed for tissue repair. An imbalance of the right amounts of growth factors, as well as cells that have diminished ability to reproduce and are senescent or slow to respond, all contribute to altered wound healing. Chronic wounds are believed to be stuck in the inflammatory phase of healing due to this altered biochemical environment.
This seems to be complicated, but your explanation has been helpful.
Yeah, this really is a complex process, and we still have so much more to learn. From what we do know about the biochemical differences in chronic wounds, we now have some understanding of why these chronic wounds, such as pressure ulcers, aren't healing despite our best efforts.
Is there anything that we can do to get the chronic wounds unstuck and move them towards healing?
Yes, by preparing the wound bed for healing, clinicians can now help chronic wounds heal. This can be accomplished by adopting a systematic approach of addressing and balancing burdens in chronic wounds. Wound bed preparation is balancing the 4 known wound burdens. They are non-viable or deficient tissue, infection or inflammation, moisture imbalance, and finally, a non-advancing or undermined edge of the wound.
What kind of treatments might we see clinicians use to address these wound burdens?
If we look at these pressure ulcers, both have non-viable necrotic tissue. The ulcer on the left with dark, hard, black necrotic tissue is an example of eschar, while the ulcer on the right with yellow, stringy necrotic tissue is an example of slough. For both of these wounds, the necrotic tissue must be removed for healing to take place. When thinking about wound bed preparation, there are 5 methods of debridement which might be used. They are surgical, mechanical, autolytic, enzymatic, and biological or maggot therapy. While there are advantages and disadvantages for each method, there are also clinically appropriate indications for each method. It's important to consider the resident's overall condition and the goals of care when selecting the method of debridement. Surgical debridement is the quickest method. It requires a skilled clinician who is licensed in the resident state to perform this therapy. This method immediately removes necrotic tissue and is used in infected wounds. It may not be a good choice for individuals with bleeding problems. Appropriate pain management is critical and is required during and post-procedure. Autolytic debridement is a natural process as it uses the body's own cells and proteolytic enzymes to soften and remove necrotic tissue. It's an easy debridement method to do, as the critical skill is the correct application of a moist dressing over the wound. The dressing is not changed daily. The length of time the dressing can remain in place varies depending upon the specific dressing category and the amount of wound fluid. Let's look at an example of this. Notice the accumulation of colored fluid under this film dressing. This is normal and we would expect to see this. The ulcer on the right is also being autolytically debrided. Notice the roll at the bottom of this dressing. This dressing should be removed and a new dressing applied without wrinkles or rolls as in the other wound picture.
What about mechanical methods of debriding?
Mechanical debridement is defined as the removal of foreign material and dead or damaged tissue by the use of physical forces. Hydrotherapy and irrigation are types of mechanical debridement that require the proper use of equipment to deliver a stream of fluid to the wound bed in order to remove the necrotic tissue. Another form of mechanical debridement is wet to dry dressings. In this method, a moist dressing is packed into the wound and covered with another dry dressing. The packed dressing is allowed to dry so the necrotic tissue adheres to the dressing material. However, it's important to note that this is a non-selective method of debridement because as the clinician removes the dried dressing from the wound, both necrotic as well as viable tissue are removed from the wound bed.
I've observed many wet to dry dressing changes, and the resident in some cases appears to be in a great deal of pain.
Yes, Sharon, this method of debridement can be painful, so the resident will need appropriate pain control during and after the dressing removal. There are several other issues that the clinicians should be aware of can occur when using this type of debridement. Trauma to the viable tissue and bleeding is also a possibility. Skin maceration, which Dr. Leiter previously described, can also occur from moist dressings. So protection of the surrounding skin and making sure that the moist dressing is confined to only the wound bed and not the surrounding skin is critical. In addition, performing a wet to dry dressing can be time consuming as it's usually done 3 times a day. Just to re-emphasize, wet to dry dressings are a form of mechanical debridement and should not be used in a clean, granulating wound.
Are there other methods of debridement that are less time intensive?
Yes, debridement can be accomplished with some enzymatic debriding agents. Enzymatic debridement is the topical application of chemical agents as prescribed drugs to break down the necrotic tissue in the wound bed. These substances are biologically capable of degrading eschar, protein, and other nucleic acids. Some examples of these chemical agents are collagenase and papain-urea. These medications are different, so it's important to follow the manufacturer's specific instructions for the frequency of application, the type of cleansing agents to avoid, and dressing compatibility.
What about the use of maggots to debride wounds?
Well, biological or maggot therapy, commonly known as MDT, has recently had a resurgence of use in the United States. It's important to understand that this is the intentional use of medically sterile maggots that are placed in the wound and covered usually with a net so they remain confined within the wound, and then they're covered with a dressing. Some residents may find the movement of the maggots in the wound uncomfortable.
That was pretty graphic.
Yes, Sharon, and while the aesthetics of this method of debridement might be questioned, maggots are effective in digesting necrotic tissue.
Dr. Aiello, should all necrotic tissue be debrided?
Sharon, that's a question that is of considerable debate among clinicians as to whether or not necrotic tissue on the heel should be debrided. The AHRQ, previously known as AHCPR, as well as the brand new WOCN clinical guidelines, both recommend that stable heel eschar not be debrided. If debridement is required on the heel, it's important that the blood supply to the heel be evaluated prior to debridement, as insufficient perfusion will impair healing. A vascular consult may be indicated. It's also important to remember that for some residents, debridement may be inconsistent with the overall goals of care. For example, when the pain of treatment outweighs the resident's wishes or their expressed advance directives.
So what should clinicians consider when debriding necrotic heel tissue?
Well, once again, the AHCPR clinical guidelines recommend assessing heel eschar for signs of instability. These signs of instability include edema, erythema, fluctuant or fluid wave, as well as drainage. If none of these signs are present, the clinical guidelines recommend that you leave the heels alone.
What can a clinician do for the heels when they are not being debrided?
Well, Sharon, the clinician can protect the heels from trauma by wrapping them with a protective dressing. Keeping them elevated off the bed mattress, as Dr. Leiter explained earlier, is also part of the plan of care. Observing the heels daily for signs that the eschar is no longer stable. That's an indication that other interventions are needed.
Is there anything else a resident or their family needs to know about debridement?
Sharon, it's so important to teach patients, residents, and their families what a pressure ulcer is and what happens when it's debrided. When it is debrided, the pressure ulcer will become bigger in size. Here's an example of a pressure ulcer that's bigger after initial debridement. Yet, a few weeks later, as the wound is healing, it will become smaller in size. Another concept that they need to understand is that a combination of debridement methods may be used. For example, as with this pressure ulcer, it was surgically debrided first, and then follow-up debridement for the yellow slough in the wound bed was treated with an enzymatic debridement agent. In fact, it's now recognized that debridement is not just a one-time event, and that maintenance debridement is needed to rid the wound bed of all non-viable tissue.
You know, I see a lot of different solutions used to clean wounds. What type of solutions are recommended?
The HCPR clinical guidelines recommend that routine cleansing with solutions that are not cytotoxic, that is, solutions that kill cells, should be avoided. This includes Dakin's solution, acetic acid, povidone iodine, hydrogen peroxide, and some commercially available skin cleansers. It is recommended that clinicians do use solutions that don't kill cells. Saline is considered the most appropriate solution. Some commercial cleansers are also safe to use. The literature also supports the use of tap water if the quality of the water is acceptable. It's also very important to remember that skin cleansers are not the same as wound cleansers. Besides using the right solution, it's also important to use a safe amount of pressure when irrigating the wound. The AHCPR guidelines recommend a PSI between 4 and 15 for wound irrigation. A 35 cc syringe with an 18-gauge needle delivers a PSI of about 8.
So now that the wound has been debrided and cleansed, what's the next step?
Sharon, the next step is to provide a moist wound environment by selecting the best dressing based on a particular wound's characteristics that Dr. Leiter has described for us in our wound assessment. Let's look at some wounds and discuss what dressings could be used. It's important to ask the question, how much exudate or drainage is coming from the wound? Basically, is it wet or is it dry? Here's a simple chart that might help you to decide on which dressing to use. It's based on the amount of wound exudate or drainage that a particular dressing might absorb. For wounds with little to none drainage, a film dressing would work. Let's look at how a clinician might apply a film dressing to a wound. It takes time for a clinician to learn the skill of putting a dressing in place. In this particular instance, let's return to the chart and the dressing categories and the amount of wound exudate. Hydrogel dressings, because they're mostly water, can only absorb a low amount of drainage. Hydrocolloid dressings can handle up to moderate amounts of exudate. For wounds with moderate to heavy amounts of drainage, either an alginate or foam dressing can be used. Remember that as the wound heals, the amount of exudate in a wound will change. So the clinician should not forget to change the type of dressing as the amount of exudate in the wound changes.
Can you give me some examples?
Sure. Here's a sloughy pressure ulcer that's dry. It needs moisture. So a hydrogel dressing is a logical choice as this dressing is composed of a lot of water. Remember that it will need a secondary dressing over it as hydrogel dressings have no adhesive properties. This wound is very wet and needs a dressing that can absorb a lot of exudate. A foam or an alginate dressing could be used. Due to the shape of this particular wound, a rope calcium alginate dressing was used as it could be easily placed in the wound. One of the secondary signs of infection is increasingly serous exudate coming from the wound. If the wound is wet from infection, one of the types of antimicrobial dressings can be used. The clinician should always check that the resin is not sensitive to the metal in the dressings, which are made of either silver or iodine. You do not send a resident for an MRI if they have a silver dressing in place. For wounds that have a large amount of drainage, negative pressure therapy might be used. This system consists of 4 things: a foam dressing, a drape dressing, tubing, and a pump. The clinician custom fits the specialized foam, which comes in either black or white, to the size of the wound, and then covers it with the special sterile transparent drape dressing. The tubing goes from the dressing to the pump, which is then set to the ordered amount of pressure and turned on. The dressing is taken off if the pump will be off for more than 2 hours.
I commonly see hydrocolloid dressings used in nursing homes. Can you tell me a little bit more about this type of dressing?
Certainly, Sharon. Hydrocolloid dressings, as you can see here, come in many shapes and sizes. They are very moldable and used on pressure ulcers in several body locations. Notice in the bottom picture that part of the hydrocolloid dressing has become very soft and mushy looking. We call this meltdown. You want to change the dressing before the meltdown reaches the edge and the dressing starts to leak. So depending on the amount of wound drainage, the dressing may be in place for 3 to 5 days.
If a dressing isn't changed daily, how can the wound be monitored and what do you recommend to be documented?
As I said earlier, based on the type of dressing used, the dressing may not require daily changing, and we may not be able to see through the particular kind of dressing, so the clinician will not be able to assess the status of the wound bed. There are, however, important resident assessments to make. These include the following. Evaluate the status of the dressing. Note if the dressing is intact and without any leakage. What's the status of the peri-ulcer area? The clinician should look for skin maceration, a sign that the surrounding skin is being overwhelmed by the amount of drainage. think about the dressing type you're using. You might need to change it. Assess for the presence of possible complications by feeling for soft tissue, infection surrounding the area, or increased ulceration. Always assess the resident for pain. Is the pain constant or related only to the dressing change? Assess measures that are being used to control the resident's pain, and are they effective?
Pain is the real issue for residents with pressure ulcers. Is there anything that a clinician can do to reduce the pain?
Yes. Here's some suggestions from our practice that you can use to reduce wound pain. For residents who have pain from manipulation of the wound, consider administering the oral medications 30 minutes prior to changing the dressing. Don't be aggressive when packing wounds, and certainly don't overpack the wound. Keep the number of daily dressing changes to a minimum. Don't let the dressing dry out in a clean, granulating wound. Remember, a wet to dry dressing is a form of mechanical debridement and therefore should not be used in a clean, granulating wound. Not only is it painful for the resident upon removal, but it pulls out the newly formed granulation tissue with each dressing change. Consider using dressings that are not adhesive and won't strip the skin upon removal. Avoid using tape to hold dressings in place, and instead consider using a wrap to hold the dressing in place. If edema is present around the wound, you might want to use a layered compression wrapping bandage system. And last but not least, choose dressings that are soothing to painful wounds. Fortunately, there are a variety of dressings available. For example, hydrogel dressings are particularly good for stinging, painful wounds.
You certainly have given us a lot of information about dressings and their role in moisture balance. Can you tell us about how a non-advancing wound edge or epidermal margin can be treated?
Of course, Sharon. Interventions for a non-advancing wound margin may include debridement, which I have already talked about, as well as biological agents such as specialized dressings made from cells as pictured here and other fibroblast-derived products. Growth factors can also be applied to the wound bed. Remember that biochemical mixture that's going on in wound fluids? Still, another approach to jump-starting the wound edges is by doing a skin graft. Along with making sure that epidermal margins and edge are moving across the wound bed, wound healing, pressure ulcer healing in the 21st century includes debridement of necrotic tissue, achieving bacterial balance, and managing moisture imbalance.
Dr. Aiello, you shared a wealth of information about treating pressure ulcers. Are there any other clinical guidelines that are available for clinicians?
Yes, Sharon. There are the 1992 AHCPR prevention guidelines and the 1994 treatment guidelines, and they're available on the web. While some of the latest treatments are not included in the guidelines, they still remain relevant today. There are also the 2003 Prevention and Management Guidelines from the Wound, Ostomy, and Continence Nurses Society.
Dr. Aiello, you've talked to us about how to treat pressure ulcers. I want to turn to Dr. Berlowitz. Are there any complications that could occur as a result of a pressure ulcer?
As with any open wound, infectious complications may occur. Among the most feared infectious complications is bacteremia, which has been associated with an exceptionally high mortality rate. Osteomyelitis is common, particularly when the ulcer extends down to bone. Deep ulcers may also extend into other structures, causing septic arthritis or fistulas with other organs. Among the non-infectious complications are amyloidosis and transformation to squamous cell carcinoma.
You know, we've covered a lot of ground, and sometimes during the survey process, I've heard clinicians mention a skin failure. Dr. Aiello, can you explain that concept?
Certainly. As Dr. Berlowitz previously mentioned, when residents have multi-organ failure with hypoperfusion, the skin is also affected. The question has been raised, can and does the skin fail? Let's use some logic at some of the arguments proposed by LaPuma in 1991 to try to answer that question. Skin is the largest organ. If other body organs such as the heart, lungs, even kidneys can show signs and symptoms of physical decline, as well as deterioration and even failure, then why is the skin not capable of failure?
Is there a definition of this emerging concept?
Yes, in 2003, Dr. Diane Langemo proposed the definition of skin failure as a condition where the skin fails due to pressure and hypoperfusion, creating an extreme inflammatory reaction concomitantly with severe dysfunction or failure of multiple organ systems, of which the skin is one.
Dr. Aiello, that's very helpful. Perhaps you can discuss another aspect of pressure ulcer care. What's the difference between restorative and palliative care?
In restorative care, our goal is to return the resident to their former level of functioning. Specifically for a resident with a pressure ulcer, it would mean wound closure. The focus in palliative care is different. In 1990, the World Health Organization defined palliative care as care that affirms life and views death and dying as part of a normal process. It neither speeds nor delays death. Palliative care provides relief from pain and symptoms and offers support to the resident and family. Using a palliative care focus, the goal for a resident with a pressure ulcer may not be wound closure, but pain relief and prevention of further wound deterioration. Wound care experts believe that palliative pressure ulcer care is most effectively delivered by a multidisciplinary team. For palliative care residents with a wound, the goals change. The wound closure may not be possible. For these residents, the focus is on minimizing symptoms. Rather than complete healing, the emphasis may be on maintaining the current status of the wound and preventing further wound deterioration or even infection. Comfort and pain management may be in direct opposition to known restorative care measures. Research supports that even cognitively impaired residents can be assessed for pain using the established pain tools. And finally, wound exudate needs to be absorbed using one of the dressings I just talked about.
What types of strategies have you seen implemented for residents at the end of life with pressure ulcers?
Well, it's important to remember that as a resident's condition might deteriorate, more time is going to be spent in bed. Based on the individual resident's assessments and needs, some palliative care strategies might include the following. You might want to reevaluate the positioning schedule and individualize the turning schedule based on the resident's individual needs and goals of the care. Small position shifts might be better tolerated by this particular resident than total position changes. You might use some pillows to bridge and protect body parts. You would expect to see the resident, family, and staff understand the decision to vary from restorative clinical care practices that Dr. Leiter and Dr. Berlitz have talked about and the possible consequences to everyone involved in the resident's care. The clinical record should contain the documentation of this teaching as well as the resident and family's understanding. As previously described, pain management is essential. Do it prior to movement, especially full position changes. Use the support services that Dr. Leiter discussed for comfort as well as prevention of skin breakdown.
What about wound care for this resident, though?
Well, I guess the ideal dressing for palliative care residents would require minimal changing, so we would decrease the frequency of dressing changes. This can be accomplished by selecting dressings that can remain in place for several days rather than hours, and there are many dressing options out there. The dressing change should have no pain or have minimal discomfort. For example, in a study done in 2002, of over 4,000 practitioners from 11 countries, they ranked dressing removal as a time of increased pain and found that the dressing type could help decrease pain. It's recommended that non-adherent dressing be used. Avoid wet to dry dressings as these are painful, and medicate the resident prior to dressing changes. Topical opioids added to amorphous gel dressings can also aid in wound pain management. The ideal dressing will address the problem of odor. To combat unpleasant wound odors, Cleocin spray 2% can be used outside of the dressing. Topical medications can also be applied to odorless wounds. Some dressings have odor-reducing elements such as charcoal, which will actually absorb the unpleasant wound odors. The ideal dressing will also minimize infection. The antimicrobial dressings, which I talked about previously, are very effective. Cleansing the wound by irrigating with large amounts of fluid are also some strategies to minimize infection. And finally, wound exudate needs to be appropriately managed by matching the appropriate dressing to the amount of drainage from the wound. For residents with wounds caused by tumors, there can be extremely large amounts of exudate. This is because tumors secrete vascular permeability factor, so fluids literally weep from these wounds. Sometimes for palliative care residents, wound bleeding is an issue. Bleeding can be controlled by using calcium alginate dressings as they have a hemostatic effect.
Dr. Aiello, this information is very helpful. Do you have any final thoughts about palliative wound care?
We're learning a lot about what palliative wound care should be, but integration of palliative care concepts and chronic wound management strategies is challenging and not yet well defined. Palliative care approaches need to be viewed as a natural evolution of treatment options. When addressing non-healing chronic wounds, the focus needs to be on providing relief of suffering and offering options that enhance the quality of life for our residents. It's important to remember that palliative care does not mean no care. Cure is not always possible with palliative care, but care certainly always is.
As surveyors, when we're evaluating the care and services provided to a resident at the end of life, we evaluate the care plan and determine if the staff is providing the care as written. In some cases, we've seen residents who, because of their condition, such as having intractable pain, have chosen to have special interventions that aren't being implemented. In order for a resident to exercise his or her right to make an informed choice about care or to refuse treatment, the facility and the resident or the resident's legal representative must discuss the condition, the treatment options, the expected outcomes, and the consequences of refusing treatment. The facility is expected to address the resident's concerns and offer relevant alternatives if the resident has refused any specific treatment. In addition, some residents at the end of life, in terminal stages of an illness, or with multiple system failures, may have written directions for their treatment goals, or a decision has been made by the resident's surrogate or representative in accordance with state law. If a resident has a valid advance directive, the facility's care must reflect the resident's wishes as expressed in their advance directive and in accordance with state law. However, the presence of an advance directive does not absolve the facility from giving supportive and other pertinent care that is not prohibited by the advance directive. For the surveyor, when determining if the development, continuation, or progression of a pressure ulcer is consistent with regulatory requirements, we would determine if the facility has done these things. First, that they've developed individualized approaches for the end-of-life care in accordance with the resident's wishes. Second, that they have implemented appropriate efforts to try to stabilize the resident's condition or documented why the condition cannot or should not be stabilized. And lastly, that the facility is providing care to manage the pressure ulcer, including pertinent, routine, or lesser aggressive approaches. If the facility uses this process, then the facility is in compliance with the regulation, even though the resident may have developed a pressure ulcer.
Thank you, Sharon. You know, from the information that all of our presenters have provided, it sounds like nursing homes have a lot of responsibility and need to really keep up to date with the state-of-the-art knowledge of current practice. Would any of our panelists, before we close, we're starting to wind this down right now, like to address perhaps some training that would be helpful to our listeners out there?
Stan, the training is a good start in the type of information that might be useful for staff. Staff needs to have access to the most current information about risk assessment, prevention strategies, assessment, and staging of pressure ulcers, as well as treatment. The staff need to know when it's appropriate to intervene and what to do. The prevention and treatment of pressure ulcer involves the entire multidisciplinary team. Knowing the resident is essential and recognizing subtle changes in the resident is critical.
Okay, Dr. Leiter, thank you very much. We do have a short time left to answer some phone and fax questions. The faxes have been coming in hot and heavy, and I have a couple of questions here for some of our panelists. First, this one is for Sharon, and the question is, when will the new pressure ulcer guidelines be available for surgeons? For surveyors, excuse me.
Pressure ulcer guidelines are presently in clearance prior to them being issued. So right now we don't have a specific date or timeline for them.
Okay. This one is directed to Dr. Berlowitz, and it says, it was stated that a BMI of 22 was cause for concern. What is your reference for this, first of all? Second part of the question, New York State guidelines indicate a BMI of 19 is below normal limits. My facility considers a BMI of 20 to 23 desirable. Please comment.
The association between BMI and pressure ulcer development is complex. In research that we have done evaluating this issue that was published in the Journal of the American Geriatric Society, I believe in 2003, we used MDS data on tens of thousands of patients. We found that at BMIs above 25, the risk of pressure ulcer development was relatively stable. However, as BMIs below 25, the risk gradually increased. Thus, patients with a BMI of, say, 20 were at higher risk of pressure ulcer development than a BMI of 22, and certainly patients with BMIs below 20 were at even higher risk. Thus, there is not a discrete threshold where the risk is suddenly apparent. Below BMIs of 25, the risk gradually but constantly increases.
Okay, Dr. Berlowitz, thank you. This question is for Dr. Aiello, and it reads as follows. Do dressing changes require sterile technique?
That's a great question, Stan, and the answer to that is it depends on many things. One of the things it depends on is what's going on with the pressure ulcer. For example, a pressure ulcer that's been recently surgically debrided, you might want to have a sterile dry dressing on for the first couple of hours after debridement and then switch to a moist wound dressing episode. You also need to check your facility's policies and procedures to be consistent with their infection control issues. The HCPR guidelines clearly state that it's okay to use clean dressings with contaminated wounds such as pressure ulcers. So again, make sure that you are in compliance with your facility's policies.
Okay, Dr. Aiello, thank you very much. The next question is for Dr. Leitner, and it reads as follows. The stage 3 wound slide had slough. If a wound has slough, how can it be, if I'm reading this correctly, how can it be staged?
That's a great question. You stage the wound based on the level of depth of destruction, and for that particular wound, you would look at the percent of slough that's in the wound. If the wound is completely filled with slough, then I would say it is unstageable. So it really depends on the level and the amount of slough that's in the wound. This is one of the reasons why, for example, in my nursing homes, we use ultrasound, because with ultrasound, high-frequency ultrasound, you actually can get a good measure of the depth of tissue destruction. But great question.
Okay. Another question for you, Dr. Leiter. When a person is seated in a wheelchair, where are the areas of pressure for that person?
That's another great question. And if you look at the work from RESNA, which is this, they're made up of a lot of the physical therapists and seating experts. When a patient is, or resident is sitting in the wheelchair, the most pressure is placed on the ischial tuberosity. So, which is why we talked about in this early presentation about offloading and getting them off of their ischial tuberosities to allow for good tissue perfusion. But most of the weight is on the ischial tuberosities. Depending on the type of chair, you may also find pressure on the coccygeal area as well as the greater trochanters.
Okay. Dr. Berlowitz, this one is for you. What other drugs that a resident receives might affect the healing of a pressure ulcer?
Certainly medications that a patient is taking may influence wound healing. The medication that one thinks about most in this case are steroids, and high-dose steroids can certainly impair wound healing. Other immunosuppressives may also affect wound healing. So those are the drugs that immediately come to mind.
Okay, Dr. Berlowitz, I have another question for you. Definition of deep tissue injury. Areas of intact skin are dark red or purple in color caused by pressure in a light-skinned or light-complected resident. Should these areas be described as deep tissue injury? And should these areas be coded in the MDS?
This certainly remains a very controversial issue that we have discussed to a limited degree during this presentation. The current recommendations are that pressure-induced injury that causes erythema or deep purple lesions with intact skin should be staged as a stage 1 ulcer. However, it probably is important in the medical record to document the difference in what the appearance is like. The reason for that is obviously in the prognosis, that the deep purple lesion has a high likelihood of subsequently breaking down. This is an area where technology may be able to help us more in the future. As Dr. Leiter alluded, ultrasound may be able to show us how these ulcers are different.
Let me add an extra component to that and ask Dr. Leiter, would the same rules apply when it comes to a dark-complected individual?
I think that becomes a challenge, because when we say in our NPRP stage 1 definition that in darker skinned individuals you may actually see blue hues to purple hues depending on the level of pigmentation, that it really can complicate how one delineates between the stage 1 as well as deep tissue injury in people of color, which is why it sounds like I've been advocating for the last hour and a half about high-frequency ultrasound, because that type of technology can tell us is that rubric, is that purplish hue that we're seeing in the darkly pigmented skin, is it superficial epidermis or is it actually down to the subcutaneous tissue or actual fascia?
Okay, Dr. Leiter, thank you very much. And all of you has shared just a wealth of information, almost overwhelming for those of us who are not very well versed. I'm speaking about myself here personally, but thank you very much. And as we start to wind down the program, is there any final thought, any final information that you would like to pass on to our viewing audience today before we leave? Sharon, let's start with you.
Well, there's one thing that I would like to bring up, and that is the fact that for the facilities as well as surveyors, looking at the prevention of pressure ulcers and looking at the treatment can in fact be a complicated and difficult thing to do. That we need to be vigilant in our assessing, we need to be vigilant in our preventative types of measures, and it needs to be a consistent and ongoing application of technologies that is in fact done.
Okay, Dr. Leiter?
Well, Stan, one thing that there are new technologies out there that are being developed for the use in research that could be used in nursing homes. For example, in one recent study by Dr. John Schnelly from the Burn Center at UCLA, a device was used called a thigh monitor. This device is placed on the resident's thigh, then electronically measures the position of the resident's body every 4 seconds and produces a report. That is, the monitor can let us know when a resident is on his back or one side or the other, how long they've been in that position while in bed. Some days surveyors may see such devices being used as a part of a facility's quality improvement program to monitor residents' positioning according to their care plans.
Okay, Dr. Leiter, thank you. Dr. Berlowitz.
I would just like to emphasize how the National Pressure Ulcer Advisory Panel may be a resource both for surveyors and clinicians dealing with issues with pressure ulcers. Certainly on our website, there is a wealth of information and resources. Additionally, people with questions can contact NPUAP members, and they will be able to get back to you with an answer to your questions.
Okay, and Dr. Aiello.
Well, Stan, as we've seen today in the program, there's a lot of information about pressure ulcers to know, and every day researchers are giving us even more information about the latest ways to identify residents at risk for pressure ulcers, as well as how best to treat pressure ulcers. As skincare detectives and clinicians, this requires us to be truly lifelong learners. It can be so challenging to keep up with all of this latest knowledge necessary to provide pressure ulcer care. Fortunately, there are several educational resources to help us. The John A. Hartford Institute for Geriatric Nursing in New York has many educational materials. For example, the Try This series consists of concise one-page handouts that contain key points on important topics specific to geriatric nursing. You can download free of charge from their website, which is www.hartfording.org. I hope that you'll find one of these Try This that I wrote on pressure ulcer risk assessment to be an easy-to-use, ready reference. The Hartford Institute also has another website, which is on your screen. This Nurse Competence in Aging website will also be helpful.
CMS has opened up the new Sharing Innovations in Quality website repository that contains summary materials on nationally accepted standards of practice. The site can be reached at the address on your screen. Documents go up in this site only after CMS and their contractor have worked with the responsible organizations to obtain permission to summarize their materials. We already have some entries about the topic of pressure ulcers, among many other topics, and we plan to add more material on pressure ulcers as our new interpretive guidelines go to issuance. This will include guidelines such as the AHRQ and AMDA guidelines, as well as all source documents used in our new interpretive guidelines. I invite our viewers to check out this site periodically, as it was specifically designed to include information relevant to surveyors and nursing home providers.
Thank you, Sharon, but I'm afraid that's all the time we have for today's program. My many thanks to all of our participants, doctors, Sharon, good to see all of you, and we want to thank all of you who faxed in your questions for the doctors and Sharon this afternoon. They were very helpful and added quite a bit to the conversation. We hope that you found this broadcast to be helpful in keeping up to date about the state of the art in pressure ulcer prevention and treatment. And remember, you can see this entire broadcast for up to 1 full year from this date at cms.internetstreaming.com. Again, that's at cms.internetstreaming.com. And copies of this broadcast may be purchased from the National Technical Information Services. The phone number 703-605-6186. Again, for copies, video copies, 703-605-6186. For information on how to purchase the title Prevention, Assessment, and Treatment of Pressure Ulcers by Medcom Video, then you can call 1-800-877-1443. Again, we want to thank our guests for being here today. We want to thank you for watching. Have a great day, everybody. Until next time, I'm Stan Stovall.